The next slide, if you see, where we can see the central line associated bloodstream infections, the third entity, which is very important again, like how we have discussed about the VAP and the COTI, same thing goes for the central line. Number of central line associated infections by number of central line days into 1000. Again, the table goes in the same way as we have discussed just now. Only thing is here there is some confusion between the CRBSI and the CLABSI and LCBI. LCBI is nothing but again laboratory confirmed bloodstream infection, LCBI 1 and 2. CLABSI is central line associated bloodstream infections and CRBSI is central line related bloodstream infections. Only the difference between this thing is that CLABSI is a laboratory confirmed bloodstream infections. Central line related bloodstream infections is again cultures which has been collected both from the central line and from the fresh peripheral line and seeing the differential time to positivity. So, that is where the differences comes. The CLABSI is more been followed in the hospital for the clinical purpose, CRBSI is more for the epidemiological workup or for any outbreak. If you see the central line bundle checklist, how we have seen the VAP bundle checklist and the COTI bundle checklist, we also have a central line bundle checklist where what best we can do to prevent the infections getting into the patient. If you see here again the central line provisional bundle checklist, again the patient details and the date of admission and the date of discharge, and if you see the bundle checklist in this here, you have the procedure before the procedure, during the procedure and after the procedure. Before procedure we can do best to avoid the central line associated hospital acquired infections is that make sure the procedure has been explained to the patient, make sure it has the proper sterile kit has been used and it has been done in a sterile environment, and assemble all the things what we required after hand washing, wearing the personal protective equipments and maintaining the sterile fluid around the area, and preparing the skin site is very important. Again we are going to prepare with 70% isopropyl alcohol with 10% povidone iodine or 2% chlorhexidine. This is what we are going to do before we insert the central line. Once the procedure has been done, what all we have done, suppose if the central line most of the time if it is done ultrasound guided, then it is more easy and it can be done in a single prick. After the procedure again the sterile techniques has to be maintained, dressing is important, this transparent dressings has to be done, and you have to see daily inspect the skin the site near the central line, see for any thrombophlebitis, again for any pain or redness or any swelling. So, daily inspection is important. Taking care of central line dressing is also a very important part after the procedure. Then coming to the next slide now about the surgical site infections, which is a fourth infection control indicator. It is a very important part again, like take into account all the type of surgeries being performed in the hospital. You can take the general surgeries, cardiothoracic, neuro, orthopedic, whatever the type of surgeries have been done, each section has to be dealt in separately with a focused study on surgical site infection. First coming to the formula again, it is nothing but again the number of surgical site infections divided by total number of surgeries into 100. This will give your surgical site percentage, how much is the percentage of surgical site infections the hospital is having. The next slide if you see now the SSI monitoring checklist from surgical OPDs. If you ask me, this is a real challenge in the hospitals. Most of the patient, as long as they are in the hospital, they can be seen, they can be traced and they can be immediately treated if they have surgical site infection. The problem comes when the patient get discharged and they go back to their homes, and if you have not given enough education or awareness how to identify the surgical site infection, then they might have even the oozing pus and they may think it is a part of surgery and they may not come back and report to the surgeon unless they land up in a very severe sepsis. So, first educating the patient, showing them the basic things how to identify the surgical site infection and asking him to contact on a regular follow up basis, and whenever they have any infection to come up immediately and to the OPD and show to the doctors. The education is very important, and second thing, give the follow up to the patients. Suppose if I have done an hysterectomy operation, give follow up to the patient, ask the patient to follow up with 7 days even if there is no problem. Then after that 7 days, based on the patient condition, you can again ask them to follow up after 1 month or 3 months. So, follow up is very important, and the most of the surgical site infections get missed in the hospital just for one reason, because the patient will not come back to the hospital, they may go to some other hospital, or even if they get the infection, they come to the OPDs, surgeon understand that this is a surgical site infection, they do the dressing and they send the patient from there without reporting to the infection control department. That is another where challenge we can come across. You need to send, I will show you in my subsequent slides, how are we going to make a surgical site infection pro forma, and we have to distribute to the surgical OPDs and make them aware, sensitized that whenever they come across the surgical site infection and the surgeon labeled it as SSI, it has to be filled the pro forma, and the pro forma has to be forwarded to the infection control department for the RCA and the CAPA for that. The next slide, if you see here, the surgical site infection surveillance checklist, again the patient details, date of admission, date of operation, and if you see the previous antibiotic history and the place of admission, all the wards and ICUs. Again it is a simple pro forma where you can fill all the details about the patient, and it can be forwarded to the infection control department once it has been filled and identified as surgical site infection. Coming to the next slide now, this is again the follow up assessment sheet. If the patient gets surgical site infection, if he is admitted in the patient hospital, you are going to record again the other markers of the infection like temperature, WBC count. If the patient is in sepsis, do the procalcitonin, even the platelet counts, which is could be a marker for the infection, and CRP, HSCRP, highly sensitive C reactive proteins. These are all the markers which will help in knowing whether the patient is having the surgical site infection or a sepsis due to surgical site infection or not. Coming to the next slide now, if you see the surgical site infection prevention bundle checklist, same how we have seen for the COTI, VAP and the central line. This is also again a very important thing where it is being followed religiously and implemented in the hospitals. It can reduce the burden of surgical site infections. See, if you see in this slide, the most important part if you see in this slide is again the patient details, patient 1, 2, 3, location, which ICU the patient is in, whether it is a general surgery, neurosurgery or orthopedic or a neurosurgical. And then if you see the hair removal, the first thing, please stop shaving. The more you do the shaving, the more the abrasions on the skin, and once the surgeon gives the incision, there are chances that the infection can happen through the endogenous flora or an exogenous flora. Always use clippers. If there is no need to remove hairs, do not remove the hair, go ahead with the surgeries. If you feel that the hair has to be removed, then avoid raising, avoid shaving the patient, do the clipping. Clippers, you can use clippers and do the hair removals. Prophylactic antibiotic has to be prescribed as per the policy. This is a very important. If you do not understand this, then again I would rather say that your surgical site infection prevention, whatever the hard work you are putting has been, almost 60% is incomplete. Hospital need to formulate antibiotic prophylaxis for surgical cases based on the international, national or local guidelines. Always whenever you are forming the policy, bring into confidence the end users, mainly the surgeons, and ask them to give the policy, see that whether it is compliant with the national policies or a local or international policies, and make sure if it is okay compliant, then you can go ahead, and if it is deviating, you can educate the surgeons about the recent guidelines and whatever the recent antibiotics being advised for the particular surgeries. They can also divide the surgeries into elective and emergency surgeries, where it is a planned surgeries and emergency surgeries and aseptic surgeries and aseptic surgeries. That is how we can do for the surgical site infection prevention checklist. And the important part is that not only the drug, the dose of the antibiotic, duration of the antibiotic, and how many hours before the incision the antibiotics has been given is very important. See, if you see the studies, most of the studies they say 50 to 60 minutes prior to the skin incision antibiotic has to be administered, because of the reason, like logical reason of the PK PD of the drugs, pharmacokinetics and dynamics, where the peak concentration of the drug will be high after 50 to 60 minutes of the infusion. So, make sure that your hospital follow the policy that giving 50 to 60 minutes prior to incision the infusion of the antibiotics. Antibiotic has to be started minimum 50 minutes to 60 minutes prior to incision, so that peak concentration can be there whenever they make an incision. Many of the hospitals are non-compliant with that. They either give the antibiotic too close to the incision, just 10 minutes before the incision, or they give antibiotic almost 4 or 5 hours before the surgery starts. In both the scenarios, your purpose is not met of giving the prophylactic antibiotic policy. So, you have to follow the policy as per the guidelines, not only the drug, but also the dose, how much duration you are going to give, and which route you are going to give, whether you are going to give IV or you are going to give through another way, and also important the timing of antibiotic before the incision. This all the things have to be kept in mind whenever you are planning a surgical prophylaxis in the hospital. Coming to the last one, again the patient's temperature, which is very important, keeping the patient temperature throughout the operation is very important, keeping the patient warm, and make sure that whatever the temperature has been required, it has to be followed. And so last, if the patient is diabetic, the sugar should be under control. Apart from that, there are many other factors which can affect the surgical site infection apart from the checklist which I have shown just now. Even if you ask me, the environmental conditions in the operation theatres plays a very important role. Your cleaning practices in the operation theatre plays a very important role, and your practices being followed, the scrub techniques being followed before the surgery by anesthetist and a surgeon and the sister in charges, nursing in charges plays a very important role. Number of person entering the OT and leaving the OT during the procedure is very important. It will also have a major impact on the patient's surgical site infections. When I told about the environmental control, I mean the temperature of the operation theatre, humidity of the operation theatre, air changes in the operation theatre, air velocity in the operation theatre, and the validation of your HEPA filters, and the placement of your AHUs, cleaning of the flange filters in the air handling units. All these factors plays a very important role. It is not like a surgical site infection. We cannot just trace and tell that it is just due to this and XYZ reason. Whenever we come across any outbreak or new cases of surgical site infection, all the parameters have to be kept in mind, and each one by one has to be audited and find what is the cause and where we can do a corrective and preventive action. This is how the surgical site infection checklist works.